All right. Good evening to everybody, and welcome to the first CME lecture done by the Occupational Health Subcommittee of the College of General Practitioners of Sri Lanka. I am Dr. Ajay Jayasilan, and I'm the chair of the subcommittee. It gives me great privilege to be welcoming all of you all actually to this first session, and very specially actually welcoming both the eminent speakers who are stalwarts in this particular field globally and in Sri Lanka. Dr. Will Ponsonby, thank you very much for joining from the UK, taking up your time, sir. And of course, Dr. Aseni Wickramatillake, who has been also a great strength to revive this occupational health part of it in our College of General Practitioners. So welcome to both of you. I take this opportunity to also welcome our president, Dr. Pushpa Veerasinghe, our secretary, our council members, and of course, all the other College of Sri Lanka College of General Practitioners of Sri Lanka members, and also the others who have joined in. It gives me great privilege to see even outsiders joining us, and we are having quite a good crowd. So thank you very much. So without further ado, I would like to hand over the proceedings to Dr. Vijay Singh, a senior member of our college, to do the honors to introduce our first speaker, who is Dr. Will Ponsonby. Over to you, Dr. Vijay Singh. Dr. Vijay Singh, are you there? You all can hear me, right? I'm audible, right?
Yes, sir, audible.
Can you hear me now?
Okay, Dr. Vijay Singh, go ahead. Yeah, Dr. Vijay Singh, yeah. It's over to you.
Yeah. It's a great pleasure again to meet you, Dr. Will Ponsonby. You know, we have had several meetings, and thank you for joining us again. He has a long story in occupational medicine. Is MBCHB, MRCGP, MBA, FFOMI, FRCP. He's qualified in Birmingham, UK in 1986. Trained in general practice and emergency medicine, 1996 ran the medical service for AIOC BP Baku Azerbaijan and regional medical director of Russia and Kazakhstan for 4 years. He was UK trained and board certified in occupational medicine, working for Shell in 2006, Shell Exploration and Production in Hague in Netherlands. Then 2010, he was a senior manager, Middle East.
Please mute your. Can you please mute it?
Can you hear me? Yeah. Afterwards, he joined.
Please mute everybody if you can. Kind enough to mute, please. Okay.
Yeah. So he's joined Rio Tinto, a very famous company in Australia, and was a CMO for 2015 to 2018. And he was based at Dubai. And he did work with the Iraq project and based in London and Singapore. He was the president of Society of Occupational Medicine 2018 to 2019. Senior lecturer in Occupational Medicine, University of Manchester, OH consultancy practice in 2019 onwards, and course director of RCPI, Diploma in Occupational Medicine. He was elected to FRCP in 2024. He's going to talk to us on opportunities of occupational medicine and I'm sure that we must be very happy that he's going to join us time to time, and to help us in developing occupational medicine in Sri Lanka. Thank you so much for coming again. I'd love to meet you again. You have come and given lectures of CGP several times, and we look forward to meeting you again. Thank you.
Thank you very much for that introduction, and it's a pleasure to speak with everyone today. And I'm coming to Sri Lanka at the end of January, so not in a month's time, so not so far away. And I look forward to working with you all to develop occupational medicine. And I'm also very privileged to be able to share with you my enthusiasm and passion for occupational medicine. And I hope that comes through in my lecture. For those who attended a lecture I gave at the College of General Practitioners for the occupational health group, this is a very similar presentation. I've used a lot of the same material, and it's very much an introduction to occupational health and occupational medicine. But I think there's a much bigger audience here, so I think it bears repeating. I'm just going to share my screen. Okay. Can everyone see my screen now?
Yes.
Yes, we can.
Okay.
You might have to put it on full screen, Bill. Okay, now you are. If we can redo it, because the side screen is also
better, no? Yeah, full screen.
The second screen is also being shown.
Okay. Sorry, this is on my computer. It's on full screen.
Maybe go back to the original and then put the full screen again. That might work.
Hold on a second.
Others, we can stick to this now, Aseni. I think it should be okay. Shall we go ahead with this?
Yeah, that's fine as well.
Yeah, Dr. Will, it's okay. You go ahead with this when we
Yeah,
can.
sorry, I'm
Yeah, it's okay. That's fine. That's fine. You go ahead with this. Thank you.
okay. So we've already covered my CV, and I've had a fantastic career working globally with occupational medicine. These are some slides working in the Jordanian desert on an oil and gas project, a aluminium refinery in Queensland, Australia, and an iron ore mine. Just a quick revision about what occupational health is. It's the promotion and maintenance of the highest degree of physical, mental, and social well-being of workers in all occupations. So what we do as occupational physicians is we help to recruit people into jobs. We make sure that they're fit to do their jobs, they're fit for task, and that they remain fit for their task during their time of work. And this may mean doing pre-employment medicals before they arrive, and then regular medicals as they go, to make sure they're still fit to do their job. We also have a responsibility to make sure that the company has an adequate drugs and alcohol program so that people aren't incapacitated by drugs or alcohol while working, that they also have adequate fatigue programs so that people don't are lacking sleep, fall asleep at work and perhaps cause an accident. And they also have sickness absence management programs and rehabilitation programs. And the last one is one of the most important things we do is when people are off work, sick or injured, whatever the cause, work related or non-work related, we have a very important role in helping people back into work. We also have an important role in health protection. identifying and managing health hazards, and Dr. Aseni will be talking more about that shortly. We also have monitor exposures and carry out health surveillance, where we carry out regular checks on the workforce to make sure they're not being exposed to anything which is damaging their health. So if, for instance, they're working in a dusty environment, we check their lungs regularly to make sure they're not developing any lung disease. And then the last thing we're looking at is well-being and health promotion. I think there's a perception among many doctors, certainly in the United Kingdom, that work is bad for people and we should protect people from work. And if we can, sign them off work. But and I think, when you look at this picture, this is from the kind of 18th century in the United Kingdom, this picture of a coal mine with child labor, obviously very poor conditions, no protective equipment, very dangerous, lots of hazards, breathing in coal dust, very poor conditions. And this type of work is obviously hazardous for health. And indeed, miners working in these conditions typically had a life expectancy in their 20s. And that is obviously very undesirable. Unfortunately, or fortunately, we've largely banished these work conditions in the United Kingdom now, but around the world, people still find themselves in these conditions. We're doing a project on artisanal mining, in the informal mining sector around the world, and child labour is still a big problem in that sector. And people are often working in very poor conditions, possibly similar to this, with no controls of the health hazards, and that will result in injuries and illness. But on the whole, if you have good work, it's good for you. It's good for your health, and it's good for your well-being and mental health. And it's also good for the economy. It's a virtuous circle, and we know that people who are working, it gives them social purpose, it gives them prosperity, and it improves their health and longevity. The other thing that we know is that it also improves the health of their family as well. It'll give, because they're working, it'll give them better housing conditions, better nutrition for the family, etc. So work has a good social purpose for the individual and their family, but it also has a very important purpose for society, because it helps to improve the prosperity generally of society, and removes from society a burden to support people if they don't have work. So I think as occupational physicians, we have a very important role in ensuring that we maintain people in their work. Having said that, we need to recognise that if hazards aren't controlled, work can be bad for people, and those hazards can be physical, and Dr. Aseni will talk more about this later. So things like radiation, noise, vibration, there can be dusts and things like that. And in this case, on the slide, we're looking at the harm done by asbestos. 125 million people around the world are still exposed to asbestos. I know asbestos is still used in Sri Lanka. In the UK, it was banned in around 1990. But despite that, we have over 2,000 people dying every year from mesothelioma in the UK, and more dying from asbestosis and from other forms of lung cancer. And globally, they estimate that 107,000 people are dying from asbestos-related lung cancers, mesothelioma, and asbestosis. And that's probably an underestimate. This is a picture of a pleural mesothelioma. And the likelihood is that most mesotheliomas are caused by exposures at work, from people working with asbestos, which has been used for lagging or for building materials, etc. These are figures from the ILO, the International Labour Organization. Occupational disease accounts for 5 to 7% estimated of global fatalities, which is very significant, bearing in mind that they are preventable diseases. And there are 2.3 million fatalities a year. Now, you might think most of those fatalities are caused by accidents, but actually the vast majority are caused by occupational diseases, over 2 million of the 2.3 million. And those diseases are work-caused cancer, circulatory disorders, lung disorders, communicable diseases, and occupational accidents only make up 18% of the total. These are figures taken from the UK looking at the exposure to occupational disease over the last 20 or 30 years. And the green part at the bottom is musculoskeletal injuries. And you can see they've decreased from over 40% down to around 10% now. And the yellow one is mental health disorders caused by work. And you can see they've gone from around 10% to around 70% now. And then the other diseases, the turquoise is chest diseases, the purple maroon is skin diseases, and then we also have hearing and other causes at the top. So some of the reasons for the kind of changes in the UK are greater awareness of mental health disorders. Also, people who previously presented with things like a bad back, perhaps they really had a mental health disorder, but they thought a bad back was a more kind of acceptable way to present. Now they feel that mental health has got more awareness. They can present and say that they're feeling depressed or anxious. And it also may be as a fact that our manufacturing industry in the UK has decreased. So less people are exposed to some of the kind of some of the hazards and heavy handling and things like that. And also, I'd like to think because we're actually protecting people better in the workplace. This just shows some of the causes of lung disease, COPD, over nearly 3 million cases, pneumoconiosis, which is fibrosis of the lungs caused by exposure to dusts. So asbestosis is a form of pneumoconiosis, but also coal dust can cause it. And the biggest cause is silica dust, and over 250,000 people dying from pneumoconiosis. And then we have asbestosis, coal workers pneumoconiosis, and mesothelioma from asbestos exposure. So the main elements of an occupational health management system are fitness for work. We've already touched on that. Health hazard management. Dr. Aseni is going to talk about that, so I'll leave that for the time being. Health surveillance. Again, I've spoken about that. That's having a program where you are looking at people and testing them. So if you have an exposure in the workplace, such as noise, high levels of noise, you should be doing everything you can to minimize those. But you should also be testing the workers to see if they're developing noise-induced hearing loss and deafness caused by that, and that would be the health surveillance program. We also need to be aware about occupational illnesses and be able to identify them and report them. We need to report them back to the company so that they can check their controls if they're working, and if we're getting illnesses, there's obviously a problem, and they then need to go back and review those and improve them. First aid in the workplace is very important, and often as the occupational health department, we're tasked with providing that and overseeing it. Well-being and mental health is also increasingly important, and helping people to manage their mental health, and also supporting them if they have problems. As well, in some companies, providing primary care or dental care may also be part of that well-being offering. And again, OH often oversees that. And the last one is community health, particularly if you're working in remote locations. It may well be that the company will support community health, and this may be by helping to support community clinics or by running health promotion, health awareness programs within the community, or working with the community to manage diseases which affect the company and the community equally. So, for instance, malaria, the mosquitoes don't stop at the fence line; they come into the factory and they can infect people there. So, you need to have a community approach to manage some of those hazards. And these are some examples of occupational illnesses. How do we define an occupational illness? We usually define an occupational injury as an immediate exposure. So if you hit somebody with a hammer, they bleed. If you cut them with a knife, they bleed. If you apply heat, you have a burn. So it's very quick, instant exposures that define what an occupational illness is, occupational injury is. Occupational illnesses tend to occur from prolonged exposure over hours, weeks, months, or even years. And often you need a prolonged exposure. You sometimes have a significant lag period before the disease presents. And that's why you do your health surveillance to try and make that diagnosis early. So examples of occupational diseases would be noise-induced hearing loss, occupational asthma caused by exposure to chemicals in the workplace, or caused by organic exposures to things like shellfish, occupational dermatitis caused by exposure to chemicals, cancers, stress, PTSD, post-traumatic stress disorder, hand-arm vibration syndromes from exposure to vibration, and musculoskeletal injuries and illnesses. This slide shows some of the disease priorities, which was a survey done by the ILO, and the survey of governments. So governments rated occupational diseases as their biggest priority, followed by musculoskeletal and noise-induced hearing loss. One of the interesting things is that mental health disorders aren't included in this list. And I wonder if this is out of date, because certainly in Europe and North America now, mental health is a big challenge in occupational disease. Health and well-being increasingly important, looking at how we support people's mental health, look at how we prevent them getting stress-related illnesses because of exposures at work, such as overwork, tight deadlines, long hours, or a bad boss who's bullying them. On this slide, it just gives some examples of the cost benefit of health and wellness programs. So for every dollar a company spends, they can get several fold of that back in benefits. And this slide shows some of that. So for instance, Citibank showed that for every dollar it spent, it had benefits of $4.50. I'm not going to go through all the examples here, but by the way, I'll make this presentation available as a PDF following the program today. So the WHO has a global plan of action to tackle health at work. So it wants governments to have a policy instruments on workers' health to protect and promote health in the workplace, improve the performance and access to occupational health services globally, provide and communicate evidence for action and practice, and incorporate workers' health in other policies. So, for instance, if you're looking at the Ministry of Health within a country, they can make provision to help identify occupational diseases or provide treatment for workers that become ill because of occupational diseases. The Sustainable Development Goals from the WHO also reflect occupational health. So Sustainable Development Goal number 1, no poverty. Obviously, if we have people working, they and their family will be financially better off, but also society will be better off because they won't be a burden on society. They'll be paying taxes, and so that helps to reduce poverty. Sustainable Development Goal 3 is to promote good health. And as we've said, good work is good for health, not only for the worker, but for their family as well. Sustainable Development Goal number 8, decent work and economic growth. And again, we've talked about that virtuous circle of good work, improving health. And it also helps to improve economic growth for the country, which makes everyone richer, and it gives the government more money through taxes to spend on social programs. Just to say that occupational health is a team game. The doctors are often the team leaders, but we have occupational health nurses who work with us and help us doing a lot of the work. Occupational hygienists are scientists, and they help us in the workplace measuring the hazards and also checking the controls and making surveys of the workplace to make sure that we're not missing anything. So highly trained, highly professional people and with a great skill set. And I have working knowledge of occupational hygiene, but I kind of out of their knowledge and expertise. Ergonomists look at the design of the workplace, look at how equipment's designed so it makes it intuitive to use for workers and also minimizes the risk of injury or illness. Physiotherapists can help us, physiotherapists and psychologists can help us rehabilitate people if they become ill, injured, have a musculoskeletal or a psychological problem, and help them get back to work. So I've visited Sri Lanka on several occasions and worked with Dr. Aseni, and we've had meetings at the College of GPs before, and also met with the Ministry of Health. And I think there's a general recognition that there is a need to kind of develop occupational health and occupational medicine in Sri Lanka. There are doctors who are working in occupational medicine now, but we need more and we need more training. And I think as well, previously you had Sri Lankan specialists in occupational medicine who were working at the professorial level, but unfortunately you don't have those anymore. So we need to look at kind of a ladder for how we can help to develop people and develop a specialty in occupational medicine. And this kind of triangle shows how that might help. So helping people who are working in occupational medicine already to get some training and qualifications in occupational medicine, and they can work their way up this ladder. I'm working with the Royal College of Physicians in Ireland, and they have professional exams that people can take, which shows that they've got a good level of knowledge in occupational medicine. The LFOM, which is an introductory exam for medical practitioners, and then people who want to get to a specialist level of occupational medicine with more knowledge, experience, training and courses can go and take the MFOM, the Membership of the Faculty of Occupational Medicine of Ireland, and that's a specialist level qualification. So I'm working with the RCPI and IHEED on a training program for occupational medicine, which is a program which runs over 27 weeks, and that brings people up to getting a diploma from the Royal College of Physicians of Ireland. And then there's a subsequent course which helps people to prepare for the LFOM exam. So if you do both courses together, that takes over a year. It takes a year, but gets you ready to take the LFOM exam. So that's kind of one of the pathways, and I'll talk a little bit more about that. These are some educational resources from the UK and Ireland. There are other resources as well. The Australian universities, James Cook University and Monash University also have programs. There's a distance learning program from the University of Manchester for an MSc. The Royal College of Physicians of Ireland, as I say, run a program in conjunction with IHEED, and I can talk more about that at a later date. But I'm a program lead for that, so I have a conflict of interest, but it is an extremely good course, high quality, and very informative, and covers the syllabus for occupational medicine. And then there are also courses and exams available through the Royal College of Physicians in London and the Faculty of Occupational Medicine. I'm a member of the SOM, Society of Occupational Medicine in the UK, and it's a great place. It's a great opportunity to join. We have a special rate for doctors in Sri Lanka. Lots of webinars, lots of educational materials on their website, and they're also linked with the International Occupational Medical Society Collaborative and the WSHA. There's also an introduction to occupational medicine lecture series on their website, which can be very useful for people who want to start to learn something more about occupational medicine. And there are regular webinars. So this is just to prove I have been to Sri Lanka previously, and this is outside the WHO, and this is one of our aims as occupational physicians, to provide people with decent work and economic growth. The other thing I should say about occupational medicine, in surveys they do of occupational medicine as a specialty, we're one of the happiest specialties. We have the lowest burnout rate and one of the highest satisfaction rates of all medical specialties. And I think one of the great things about occupational medicine is we're there to help people, and we're there to prevent disease. We don't treat disease, we help prevent it. And if we identify disease, then we refer it on to one of our colleagues in the clinical specialties. And for me, that's very motivating, the fact that we're preventing disease. We're going to have a Q&A in a little while, and I'm at the end of my time. But these are just some of the things I thought about, questions about what we want to do in Sri Lanka. So there were occupational medicine specialists in Sri Lanka previously. How do we re-establish that, or do we want to re-establish that? And do you see occupational medicine being a specialty or a subspecialty? And where should it sit? So in the UK, occupational medicine sits in the Faculty of Occupational Medicine in the Royal College of Physicians. In America, it's seen as a public health specialty and sits there. Or should it sit in the College of GPs? Well, you're obviously very interested and motivated, so maybe that's the best solution in Sri Lanka. And then, we need to look at how do we support the development of occupational medicine? What education is required? What exams and qualifications would be suitable? And how do we set those up? And as I said, government support is very important. Aseni and I met with some of the people in the Ministry of Labour when I visited previously, and they're talking about updating occupational health law in Sri Lanka, which is still which is out of date, and a lot of it dates back to the colonial period, and that needs to be updated. But also, because this supports economic development, it's good if government support that, because obviously that's in their interest. Okay, so that's all I have to say for the minute, and I'm going to hand over for Dr.
Yeah.
Ajay.
Dr. Will,
Ajay.
Dr. Will, thank you so much. It was quite an informative lecture, and I think it came in an hour of need where, occupational health is something which is quite developed globally. And for some reason in Sri Lanka, even though we have many doctors working in companies and in occupational health, still it is a little bit in a primitive level. So just to keep you all informed, it's all in initiative stages. Thanks to Dr. Aseni, who is the backbone and the strength of all of our activities to revive this through the College of GPs. We are trying to sort out a course which will take some time. So hopefully that will come into play. Also, there will be a little bit more CMEs, some workshops which we are planning for the corporates. And also, if all goes well, Dr. Will be here end of January. So we as the council are trying to do a panel discussion, and we will inform all of you all. It will be passed on, and I hope this can be worked on. There is not much of time. If possible, we are trying to do that, just for your information. All right. So thank you very much again, Dr. Will, and thank you very much for all of you all for joining in. We have a good crowd today. So moving on, I think this personality needs no introduction for people who know her in the occupational health field. She's one of the stalwarts in Sri Lanka. And Dr. Aseni Wickramatillake, MBBS, MPH, Occupational Health and Safety, MBBS, also Diploma in Cardiology, work experience in the National Health Services in the United Kingdom, Masters in Public Health with a focus on environment and occupational health safety from the University of Louisville in the US. Trained as a lead auditor in ISO 45001. Visiting lecturer, University of Moratuwa, and University of Vocational Technology and Chartered Institute of Personnel Management, member of the Southeast Asian Leadership Academy Leadership Program, and Secretary of the Workplace Safety and Health Association, WSHA, in Sri Lanka. National Secretary of the International Commission in Occupational Health, ICOH. Board member of the Workplace Health Without Borders, WHWB. International branch member of the Society of Occupational Medicine, SOM UK. Trained mentor through the ROSPA, L'Oreal, and Nike programs for global women. in safety and health, empowering women in this field. Research in occupational health-related content, including publications in prestigious international, a very attractive CV, of course. And she is a person who is representing Sri Lanka globally. So the topic she will be talking on is the impact of occupational chemical exposure on worker health in Sri Lanka. Thank you very much, Aseni. Over to you.
Thank you, Ajay. Thank you very much for such an illustrated introduction. Good evening to everybody. I will be following up on what Dr. Will had said, the importance of occupational medicine, occupational health and well-being among the workplaces. So I will talk about chemicals mainly, but I need to highlight that at workplaces, we need to understand that there are many types of hazards that people are exposed to, which can cause immediate issues in our health as well as long-term issues. Some may have long latency periods where, you know, nothing is happening, but suddenly after many years of exposure, people get ill. So we also need to understand why workplaces are important to everybody, because majority of us may start working either at the age of between 20 to 25 years of age, and then our retirement age is between 60 to 65. So and most of us work 5 days a week, or in factories, it's way more than that. So if we look at that, majority of our time, you know, the waking time, we are at work. Or so workplace, I mean, we look at the health at home and within our environment, but workplace health also matters. Our exposures at our workplaces matter a lot in keeping us healthy. So because of that, we have to, you know, as medical professionals also, we have to look at when we see somebody, we have to ask what type of a job, you know, take a history of the workplace. So ask what type of a job are you doing? What type of hazards you may be exposed to? Because there may be various hazards that people are exposed to, maybe just one single one or multiple hazards. So today I'm just going to talk about the impact of chemical exposure at work. So what we need to understand when we talk about chemicals is that, I mean, in today's world, there's a lot of various chemicals available. So even at workplaces, there will be a huge number of chemicals that are available. So we need to understand what the hazard is. What is a hazard? Hazard is what may cause harm to people, right? So what type of hazard is that? And then how does the hazard get into people, the exposure route? And then what is the risk? Once this harmful substance, once it enters our body, what does it do in our body? How does it cause harm? And what is the risk? So once we understand the severity of the risk, we need to find ways to control it, because we need to understand that occupational medicine is mostly about preventative health, how we prevent people from getting sick rather than treating people. Of course, we treat people after getting ill as well, but it's mostly a preventative based profession. So if I dig a little bit deeper into the chemical characteristics, actually, we look at physical forms. You know, that I have listed a multitude where it can be liquids, it can be gases. So what happens here is how it may get into us, because if we take a gas, a vapor, a mist, it may be suspended in the air, and it may be in the air for a prolonged period, and that way it may get into our lungs. So sometimes liquids may fall on our skin, our eyes, and get into us. The other thing we need to understand is the type of hazard. What does this hazard cause, right? So most of the hazards can be flammables, or, you know, and then it can cause corrosion. If it falls on our skin, it can cause, you know, a burn or a corrosion. Then the other thing is how poisonous are these? What organs are they going to damage? Is it a single organ? Is it multiple organs? How far is it going to damage, and how what's the duration? Then, of course, we know that some of these chemicals that we are exposed to, like what Dr. Will said about asbestos. Asbestos causes a cancer called mesothelioma. So when we are exposed to these chemicals, we may end up getting cancers. People may end up getting cancers. So what chemicals would cause what particular cancers? Because some chemicals are very specific in its target, where the cancer would form. And then we have the irritants and the sensitizers. So these are the type of harm that chemical exposure can cause to us. We also need to understand what the environmental, how much of a temperature people are exposed to, what is the humidity level. All those affect the level of exposure. Then also, of course, we always look at the individual susceptibility, right? The age, the gender, and all that. So if we dig a little bit deeper, I just want to talk a little bit about these particles. Particles, we heard a lot about particles when we were going through the COVID period, because COVID itself mattered a lot because of its particle size, because it was so tiny. It was, the weight was not so much. So it's suspended in the environment for prolonged periods. So that is why the particle matter, particle size and weight matters a lot. Because if it's heavy, it would fall on the ground, it would get on the surfaces much quicker. But if it is much lighter, it's easier for us to breathe in, and because it's suspended. Then the shape matters as well. Like if we talk about the asbestos fibers, right? The way the fibers are made, it may penetrate deeper and may hook on more firmly. So the size, the shape, and also the chemical composition, because some of these dust, if we talk about silica dust, if we talk about asbestos dust, if we talk about even tea dust, any dust, if we talk about it, it may have various chemical compositions. So that chemical composition itself can harm our body in different ways. So it's not just the dust, but also the chemical composition in it. So here in this picture, you would see the size of these nanoparticles I'm talking about. The long rod is a strand of human hair. And then, the brownish color thing is a fine beach sand, which we all know how small that is. So these particle matters that I'm talking about are so small, it's one of those blue little circles that you can see. It's that tiny, which we cannot see to our naked eye. And those can have chemicals embedded in those. So if we talk about the routes of entry, the major route of entry is through our respiratory tract, because naturally we all breathe in, right? So we cannot stop that. So it just gets on and it's suspended in the air, and it can get in through our respiratory system. So that is the main form all these harmful substances at workplaces can enter our body. The second most prominent method is through our skin. It gets absorbed through our skin and then slowly accumulates or causes damage. It can cause systemic damage, but the entry route is through our skin. Then somewhat less is the digestive system. Here I have put those forms clearly so that you have, when we look at the entry route of respiratory inhalation, we have to look at the hazard type, its solubility, whether it's lipid soluble, water soluble, then the activity and the respiratory rate, because when we are energetic, we breathe more, right? And so because of those things, we may inhale more harmful substances. Then what kind of protective equipment are we using? Are they suitable to stop those particles from inhaling, all those chemicals from inhaling? Then the severity of the exposure, I'll go into detail later on. Then what type of reaction will it cause in our body? Will it cause an acute reaction, a chronic, or a local, systemic? What type of? Then if we look at skin, the wetness of the skin, are we sweating? Because most of these workplaces, especially the workers who work in there, are working under very hot, humid conditions. So are we, the moisture on our skin might affect the absorption. And then where does these chemicals get onto us? Which part of our skin, which part of our body? In the vascularization, obviously the absorption is much greater. Then if you have further skin damages, would that affect the absorption, right? So likewise, I have listed, I'm not going to go through all those, but those can affect the level of absorption through the skin. Then ingestion, which is not a major route, if we are always, touching our mouth, if the hand hygiene is very poor, those are the ways that it may get ingested into our body, the harmful chemicals. There are other ways that substances can get into us, that is through the maternal breast milk, then injections, and those are very minor levels. Of course, in medical doctors, the injection might be one of the prominent ways harmful substances accidentally get into them. So if we look at these, the severity of this toxicity, the exposure matters a lot, which is the dose. In the 1400s, this great scientist, Paracelsus, he said, dose makes the poison, right? So dose matters a lot. How much are people getting and how frequently are they being exposed to? Is it once a week? Is it every day? Is it the full day? And if they're exposed, how long are they exposed? Is it for just a few seconds? Is it for the whole day? So, and how long, and the rate, how much is getting absorbed into our body, and how much is it distributed? Where is it distributed in our body? Right? Which part is it going to be distributed? Then the biotransformation that happens in our body. All these things, and the excretion. Where does it excrete? Because all these chemicals, when it excretes, that also can damage certain organs, excretory organs. We also need to understand is that when we talk about chemicals can act individually, because no organization works on a single chemical. They manage a lot of chemicals. So people may be exposed to a multitude of chemicals. So sometimes what happens is these chemicals may give an additive effect or a synergistic effect, right? So the harm may be multiple times than what a single chemical would cause. So that also we need to understand that, we need to know a lot of what type of chemicals that people are exposed to at work. So if we look at how do you identify hazardous chemical, this is a picture I have taken at a workplace. So this is the level of chemicals that some workplaces handle, right? These are tanks full of different types of chemicals. These are liquid chemicals, but there are also powdered chemicals. So that is when the dust matters as well. So how do you identify chemicals? Chemicals are identified by their labels or their safety data sheets. Every chemical which is imported or manufactured in Sri Lanka should have a safety data sheet. It gives all the information about the manufacturer, where it's made, the content, and its toxicological data. I'll go into, so this is a label, what the label should contain. I'm just giving you all a brief overview. There will be a picture, you all may have seen, different pictures, then a warning, what type of a harm it may cause, then what is the first aid that should be followed. So all those should be on the label of any chemical. And then if I talk about the safety data sheet has many sections, right? So here you would see section 1, section 2, section 4, which is first aid. Section 9 is about the toxicological information. That gives you in detail whether it's an irritant, whether it's a carcinogen, whether it's a sensitizer, and whether it's the skin, the eyes, whether it's the respiratory, whether it's the liver. So it gives more specific details on the exposure. And even in the hazard section, section 3, it will tell about the health effects, the acute health effects and the chronic health effects if the studies have been done on human. If not, they will give animal data. So even on a label, these are the typical type of labels that are on chemicals, and the blue colored number 1 will always be about health. Right. So once we identify what the chemical is and its chemical compositions, we need to understand the risk of exposure. So risk equals likelihood into severity. So we need to see how likely is one being exposed to the harm and how severe can it cause, how badly, how much of an effect it can cause on our health. So that's how we categorize it on the likelihood and the severity. So I've just drawn up a little table so that you all can understand how this the low risk, medium risk, high risk, and the very high risk can be calculated according to the likelihood and the severity of it. So the response, action, and the time scale is always determined by the level of risk. So how much do you act on it and how quickly should you act on it is determined by the level of the risk, right? So now we come to controls. Controls is what protects people. That's the most important thing. The previous ones is to identify the harm of it. Now, to protect the people, to prevent exposure, is this controls is what matters the most. So there is a hierarchy generally in occupational safety and health, we have a hierarchy of controls. The main way we should control harmful exposure is through elimination. If a chemical is carcinogenic or it is a reproductive toxin, or it is a mutagen or a teratogen, normally best is to eliminate the exposure. So eliminate use of that chemical. But sometimes we may not be able to, right? Then we may have to substitute it to a less hazardous chemical, right? Which works this in a similar pattern. Failing which, the engineering controls. I'll come to those. And then the administrative controls and the PPEs. PPEs are the last resort because PPEs don't protect all people, and PPEs are dependent on how well people are wearing those PPEs. Because if you go to a work site, you will see sometimes the masks are not proper. The masks are, the proper masks are not worn, and the masks are not worn properly or maintained properly. Even the hearing protection, most of the time it's like that. So so if they're not worn properly, if they're not used properly, the person will not be protected, and there will be a false sense of security for them. They feel that they're protected, but they're not actually protected. So if we look at engineering controls, one of the main ways of engineering controls for chemicals is ventilation systems, right? The circulation, how much of circulation within a room should happen with natural air. And when you have an inlet and an outlet of the fans, exhaust fans, how do you put it? That's very key, because it should not pass through a person. It should not expose a person. So even the fume hoods, you need to understand how. So sometimes what happens is people say, oh, there's a fume hood, but in clinically you would say that this worker is exposed because the fume hood placement may not be correct. Even though there is a fume hood, you sometimes may need to dig a little bit deeper and ask, what type of a fume hood is it? Or, does the extraction happen properly? So those are things that you may have to look into. Then if we go into administrative controls, administrative controls are what the management would have in place to prevent people from exposure. That is, they would have an inventory of their chemicals, so they would know what the harmful chemicals are, what the milder chemicals are. So they would have their safety data sheets and the chemicals well labeled. They will have a good chemical management plan. And if there's any incidents or exposure risks, those will be recorded, those will be investigated to prevent future exposures. Then there will be, from time to time, there will be environmental monitoring to see whether there is a leakage. If there's a smell, there will be a monitoring done to see what level of exposure is. That part mainly comes from hygienists who would monitor the amount of chemical within the environment. Then, like Dr. Will said, the medical and the health surveillance. And then on other aspects is the safety aspect, where you may have spill kits and first aid equipment, fire safety equipment, because we should not forget some of these chemicals can be flammable and explosive. So this is what a workplace, I spoke about the protective equipment. Especially when we are handling chemicals, we need to make sure that the protective equipment, whether it's a respirator, whether it's a pair of gloves, or aprons, or whatever we wear, we give to people, are chemical resistant, right? And they're actually defined to use for those particular chemicals. And then there are other safety equipment that are available at the site of, where chemicals are handled and chemicals are stored at workplaces. Now, in the top picture, if you look, there is a little sink. That sink is an eye wash fountain, where if chemicals are sprayed on the eyes, people quickly go and wash it continuously for about 15 minutes so that it's diluted. That is the main way of first aid, so that the damage is minimized. Same way, in the middle of factories, there would be a shower, right? So if people have chemical splashes, or, there are accidental spills on people of chemicals, they would run to the shower, and fully clothed, they would just wash it away, try to dilute it, and stay under the shower for about 15 minutes. So that's how, when chemicals are handled at workplaces, these are other equipment that should be there to prevent further harm. So I'll also, I'm a little bit aware of the time as well, but I'll quickly share at least one or two case studies that has happened at workplaces due to chemical exposure. In 2018, I think, yes, 2018, there was in a rubber factory, there was an ammonia leak. So what happened was, during the Aurudu, the New Year holidays, this tank was closed for a few days, and then people came back and started cleaning it up. So one person went, and there was a lot of, initially it was believed that it was only ammonia gas, but later on they found out there were other toxic gases as well, toxic chemical gases as well. And this person breathed in that gas while cleaning this tank, and then collapsed, right? So a fellow worker saw this, and 3 other local residents saw this, and then they rushed, without knowing why this person collapsed, without knowing the actual understanding what the hazard was. They also rushed to help him. But unfortunately, what happened was, all 5 of them died, because they did not understand the chemicals. And a lot of other people were hospitalized as well because of this toxic gas inhalation. So if we talk about ammonia itself, ammonia is colorless, so you won't see it, but it has an odor. And it's lighter than air. So what happens is it goes up, right? So people who are standing, people who are up, it'll go out and they'll all breathe it in. And it's highly soluble in water. So even our mucus, when it touches, it can react. So because of that, we had to be very careful. So it reacted. What happened was, it reacted with the moisture, and then formed a chemical reaction, and then which is very corrosive. So it caused tissue damage and necrosis. So it can cause, like I said, inhalation is one of the main routes of entry. So it caused, throughout the breathing system, respiratory system, it caused severe damage, right? Severe pulmonary edema, lung damage, and even skin. Because it's a corrosive, it can cause significant harm to the skin, the eyes, and if it gets through the mouth, again, it'll cause ulcers and things like that. So that is acute. But then sometimes there may be small ammonia leaks, right? So it's not a lot at a time, but it will gradually, people may be exposed to it for long periods. So then what happens is it can cause chronic irritation and also get into, cause fibrotic changes and skin irritations on the long term. So these are what, then another example is the chlorine. So again, I think that this was in 2023, I think, or 2024, I forget. The multiple chlorine leaks have happened at industrial zones, right? So a lot of people were hospitalized because they had difficulty in breathing. Then I'm sure in, I forget again which year that was, but I think in Colombo, there was a significant incident where school children were exposed to chlorine when the pool was cleaned while they were in the pool, right? So that has had a significant health effect on those few of the children, because the handling was not of the pool chemicals were not done properly. So if we take chlorine, chlorine has a strong irritating odor and it's much heavier than air. So what happens is it goes down. So children were in the pool and the chlorine goes down. So it gets into the lower levels of the surface, right? So that's how those children inhale so much of the chlorine gas. So we need to understand some of these, the characteristics, because then we know how to protect people. And it's it's an oxidizing agent, a strong one, and it's highly reactive. So again, it causes corrosion when it touches water, right? But it's not flammable, but it can be combustible with some material. And I have known where when people were mixing chemicals for pool cleanups, there have been fires ignited as well, small explosions happening. So again, similarly, chlorine also can cause tissue damage because it's acidic, right? So respiratory, skin, on the acute effects, as well as chronic respiratory because of the high levels of acidity in the chlorine. So ammonia, if we talk about pools itself, since we are on the subject now, workers working around pools are the lifeguards and the pool staff, the cleaning staff. So pools, ammonia, because through a human urine and excretory material, ammonia can be significant in pool water, right? And that mixing with chlorine can react and give out these chloramines. So this trichloramine can be very highly, cause sensitization and irritation on our skin, eyes, or the respiratory system. So that can be very damaging on the long term. So these lifeguards and pool staff may have skin issues, breathing issues because of this, right? So I took a little bit of time extra. So that's about it from me. Ajay, thank you very much.
Yeah, thank you so much, Dr. Aseni. I think you really enlightened the whole audience, and we got even though it is a brief sort of a session, I think you touched on a lot of areas, and then you enlightened the importance of occupational health. I think everybody, regardless, will agree that it has to be developed in Sri Lanka. I mean, you can see by both of these eminent speakers that, it's just occupational health has so much to do with. And I think as, in any field we are, especially I think the majority are family physicians and GPs here, but I think we have enough and more other people also around. I think every single workplace has that link to occupational health. It can be from a small clinic to a hospital or anywhere you work. I think occupational health is a very important factor. So thank you very much for both of you all for coming in on a Sunday and spending time with us. just to keep everybody enlightened, the next CME lecture has been confirmed for February 22nd, Sunday at the same time. We'll be informing you all. It will be Dr. Asela Anthony, again a senior member of our college, who will be interlinking occupational health with actually GP practice. So that will be another good thing. And also the presentations of both of these lectures will be sent to each one of you all, so that you will be having it. So in the long run, I hope all of you all will join us, and then hopefully we can develop this field much more with all your help. We are going to open up a few minutes because we have enough time for question and answers. So, I mean, you can direct it to either one of them or both of them. So you can mute and talk. Is there anything on the chat box? I don't think. Okay, so there's one. There's yeah. So Rukshana said there is a MSc program about occupational health and safety in the University of Colombo. Yes, there is. I think recently, Aseni, they had advertised for everything. I think. Yeah, you can elaborate.
Yes, it's a general MSc on that was recently started at the Colombo University, and Moratuwa has been having it for the last I think since 2013 on occupational safety and health.
But there is, you should, I mean, I think you have to do the diploma, a certificate course, diploma and bridging, right, Asani? I think that's how it works.
For the MSc, if you have if you have a degree, and then you don't have to have an occupational health, safety and health background, you can join in later as a MSc. But there's no degree program at the moment on occupational health. But there's a diploma and master's.
Master's, right. Okay. Thank you. Anybody else has any questions? You can direct it to both of them. You can unmute and talk.
Just to follow up on the previous point, I think one of the things is occupational medicine is different from occupational safety and health as well. So occupational medicine is much more about diagnosis, recognizing occupational disease and preventing occupational disease. So I think the two courses complement each other, but the course content is quite different. And in occupational safety and health, they'll touch on health, but not in so much detail.
All right, thank you. Thank you. Any other questions from the audience? We have enough time. Anybody else wants to ask anything? All right. So I guess it was pretty clear because both of you all really sort of gave a brief but a sort of a good picture about occupational health. I think everybody would have basically had a good understanding. So I hope this field, of course, with the help of both of you all and others, and also of the College of General Practitioners getting involved, that we can actually develop it more, and hopefully in 2026 from that we see some sort of a development in this. So I thank both of you all again, and thank you very much for all of you all for joining in, and see you all soon. Thanks a lot. Take care. Have a nice evening.
Thank you. Good night.
Thank you.
Good night.